think we are ready to get started. So I'm going to go ahead and introduce our first presenter. So our first presenter of the evening is Dr. Monty Ghosh. So Monty Ghosh is an internist and addiction specialist who works at the U of A hospital in Edmonton as an internist, as well as the Sheldon, Coomer, and Rocky View hospitals doing addictions medicine in Calgary. So Dr. Ghosh's research focuses on addiction and substance use disorders, as well as linkage to care and health equity needs for those experiencing extreme vulnerabilities such as homelessness. He has led several provincial initiatives with Alberta's Health Authority in providing supports for this population during both the COVID-19 and opioid crisis. So Monty, we are really glad to have you here and you can go ahead with your presentation. You should be able to share your screen. Yeah, perfect.
Great. No, thanks so much for having me here. I'm really excited to talk to you guys. I see there's a lot of experts on the call as well, on the Zoom call. So glad for you guys to chip in as well. I first of all want to acknowledge the land we're on. So we're in Treaty 6, 7, and 8 territory. Yeah, really appreciate the opportunity for being here again. I'll just get started. So I've got a lot of slides, and I'll try to make sure that I get this done within my 20-minute allotment. I'm happy to answer more questions afterwards, and it can go back to some of the slides as well. So that's just my disclosure. So in terms of the opioid crisis, we know that's been ongoing now since I think it really started reaching us at 2016. It's been there before then, of course, as well. But that's when we really start to see the effects of the opioid crisis. COVID has made things much worse. Throwing out some numbers here for you guys, but since the pandemic started, we did see a decrease in overdoses initially around April, if you look at the opioid overdose reports, but that's since tripled in size. So right now we see 3 times the rate of opioid overdoses in our communities compared to what we saw last year, for example. We've also seen a concurrent 50% decrease in individuals accessing addiction mental health resources in our communities. This includes opioid agonist treatment clinics. This includes residential treatment facilities. This also includes supervised consumption services. We've seen a huge decrease in supervised consumption service utilization in the province. And Lethbridge, especially with the closure, we've seen it down to almost 10% of where it was before. So that's a huge reduction in numbers, which is quite concerning. We've seen a large reduction in detox uptake as well. A lot of this is because of physical distancing. Right now, our main detox facilities such as Renfrew in Calgary and ARC in Edmonton are down in size because they have to physically distance and respect public health recommendations. Opioids in general do cause immunosuppression. We know this from various different studies. And so I highlight this because I want to make sure everyone understands that this population is highly vulnerable. Those who are using opioids on a regular basis, they may not do well with COVID positivity. So really going to keep that in mind as I go through this talk. We really need to prioritize them for this reason for supports during the COVID crisis. One of the big things that we're advocating for during the COVID crisis, of course, is to add more supports for this population group. We do know that because of the COVID crisis, because of mental health acuity that's happened because of the crisis, because social isolation is there, because we're being distanced from people that we interact with, our family, our friends, things have worsened. We also don't want to make it worse from a service provision perspective as well. So we want to provide supports for our clients for those pieces like addiction, mental health concerns, providing them with social supports as needed, providing them with more care and access to care. But we also want to remove care from them, which is what this slide is about right here. We want to make sure that we're providing them the right doses. We want to talk about needs of those needing shortened dispensing intervals for their opioid agonist treatment. And we don't want them to also come to clinic unless they absolutely need to. And this has become a problem for us in our communities, because you have to try to balance the issue of public health concerns and public health restrictions from not being there for your patients on a face-to-face basis. I have lots of patients who ask me, they tell me that they want to talk to me in person as opposed to over the phone or over telehealth, and that's been difficult for them. We are moving towards virtual care right now. So that is something that we have throughout the province right now. The province has put a virtual compensation piece around this as well. This allows us to see patients virtually, talk to specialists virtually, It reduces the spread of community healthcare, reduces the spread of COVID amongst community healthcare workers. Uh, I added this because this was for a previous presentation I did for physicians, but we weren't very well compensated before, but we are now. In terms of opioid agonist treatment, I don't know again how much you guys know about this, but we've tried to make it easier for our population to get the medications that they require during this pandemic. So opioid agonist treatment is a controlled substance. And for that reason, there was numerous restrictions that were put in place systematically. So we had methadone restrictions, for example. We could not dispense methadone unless it was daily dispensed from a pharmacy and witnessed. We had to restrict Suboxone to a certain extent as well. Not everyone could prescribe Suboxone. Not everyone could. Like we didn't advocate for this before, but this was very apparent with the many practices about daily dispensation of Suboxone. That has really changed a lot now. A lot more physicians, for example, are prescribing it on a regular basis. Not having daily witness dosing, for example, as well. Not asking for urine drug screens. And the pharmacies themselves are allowed to extend prescriptions now, which wasn't the case before. Before you had to get physician permission to do that. That is no longer the case. Some other things that we've changed in our practice for this is we suspended all urine drug screens. We've tried to deliver drugs where possible, opioid agonist treatment where possible. We don't have daily witness dosing of Suboxone, which again was something we never really advocated for, but was something that was being practiced in our communities. We've also tried to do more home inductions of Suboxone. So before, people would have to come to clinic to start on Suboxone to deal with the opioid agonist, to get onto opioid agonist treatment and deal with their opioid use disorder. But now we're actually encouraging them to use this at home and start on their own at home. We provide up to 60 days of dispensing. We actually ask for carries now of methadone. And we've been trying to reduce the amount of methadone in our communities, and we're trying to rotate people to Suboxone, which is much more protective. I just want to paraphrase this with the fact that I don't know how knowledgeable people are around these things. But from a healthcare perspective, these are things that we're doing. The other piece that we're doing is we're actually trying to get physicians to not fire their patients if they're using opioids. And that's been a huge piece of advocacy that we're doing right now. A lot of times with the COVID crisis, clients are, again, in mental health crisis. They're having difficulties. We do see a lot of physicians who don't have as much understanding of trauma-informed care, who are letting go of their patients. And we're trying to push them towards a better understanding of how to deal with this. I think I've already went through the slide. Some things that have changed in our practices have been IOT, for example. So IOT is the injectable opioid agonist treatment program. So this is a form of treatment where people come in twice to 3 times a day to a clinic where they get offered opioid agonist treatment. And here they're allowed to inject, consume opioids that are prescribed by a physician. It's a form of safe supply. And it's a really healthy way of engaging with this population. We know that for this population group, it's hard for them to engage with healthcare workers, but this is an access point into the system. And that's how I look at it from a systems perspective as a physician. We provide wraparound services for them. We get them care through uptake to housing, income support. It's really the wraparound services for this service that provides that really helps with these clients. That's kind of like our sweet sauce, is that wraparound piece that's so essential. Things have pivoted with this practice with the opioid crisis. Now we're trying to transition to more opioid equivalents with oral opioids. We have this thing called the blue drink that we provide our clients to take home with them. We provide carries, we go and dispense it to them, we visit them in their homes. We've had a few clients who have had to isolate because of COVID, and we have a mobile team in Calgary specifically that'll go out to treat these individuals. In terms of protecting our people who use substances and all patients, we try to provide education around them. And that's been a huge pivot in our practice. I mean, we've always provided education, but now we're being asked to talk about public health issues. Now we're being asked to talk about COVID and how COVID relates to them. As I mentioned earlier, our clients are highly vulnerable. They not only have opioid use disorder, which increases their risk of having poor outcomes from opioids, but many of them have other concurrent risks as well. They've got risks of smoking, which puts their cardiovascular risks at, increases their cardiovascular risk. Many of them have other comorbidities. which we know lead to poor outcomes, so mental health and understanding of COVID. We know that many of them have COPD, many of them have issues with diabetes. Homelessness itself is a huge risk factor. We see that there's a 20% increase in rate of admissions to hospitals, 10% or 10 times the rate increase of hospital ICU admissions, I should say, and 5 times the increased risk of dying from COVID. So we really try to educate the population on this. We talk about buddying up for using if they're going to be using alone. So we ask them to not use alone, but also maintain that 2-meter distancing. And we ask them to continue to use supervised consumption services and overdose prevention sites as much as possible to keep them healthy and safe. Other harm reduction things that we're educating them on is to not share supplies if possible. One of the things that we were running into some of our shelter sites in Calgary and Edmonton include their use of sharing substances and sharing paraphernalia, which we encourage them not to do as well. So we encourage them not to share cigarettes, joints, injection equipment. We educate them on how not sharing drinks is key, like so not sharing alcohol, for example, even though there's this thought that alcohol might kill the virus. We talk about wiping down their paraphernalia as well. We talk about reducing close contact, so reducing shaking hands, hugging, kissing, ensuring condoms for safe sex practices, and also washing their hands in between preparing their substances and preparing their substances themselves. Again, basic public health measures here. So cough in your elbow, clean your surfaces as much as possible, carry naloxone, have an overdose plan. Please use breathing masks where available if you can, again, to limit the spread of COVID. We have had some changes with our practices for overdose responses within the shelter site specifically. So for example, we're providing naloxone kits and using nasal prong oxygen, but we're not necessarily doing CPR. And we have some data that demonstrates that it actually hasn't really impacted things as much as we thought it would. And again, this is because of the pivot for COVID, and it's not ideal, but it's things that we've had to make a move on because of the crisis. Other things that we're doing is that we're trying to screen, and this is occurring not only in clinics, but also in our shelter spaces. So we're screening clients for COVID symptoms. We're testing them if we can in their space that they come and see us at. We've created isolation spaces for this population group. We're trying to manage issues such as PPE, increasing shelter space so that people can practice physical distancing. And the other thing that we sort of created was a program to help support individuals who are using alone. And so this is something that Azra really wanted me to touch on. Was the NORS project. So this is a project that's led by peers at the Grenfell the Grenfell Ministry, which is a community-based organization in Hamilton, Ontario, as well as a group in Vancouver called Brave. And what it is essentially is it's an overdose prevention service over the phone. So for example, right now we know that 60% of opioid toxicities occur in people's homes. This is based on Alberta data. We see similar data in Vancouver and BC. We see similar data in Ontario as well. We know that the majority of people who overdose are overdosing outside of the therapeutic efficacy of supervised consumption services. Supervised consumption services are a gold standard. They reduce mortality within 500-meter radius and up to 1,000 meters around them. But beyond that, there's no reduction in mortality rates. And we know the majority of overdoses occur beyond this. So good news is we know that that naloxone is effective. It reduces opioid overdoses. We know that supervised consumption services do reduce mortality rates, but they do have geographic limitations. And so in partnership with these agencies, we've created this service that exists. It's a toll-free number that you call, you provide to your patients so they can use substances and not use alone. They call a 1-800 number, a volunteer connects with them, and they'll stay on the call with them for 15 to 30 minutes as they use their substances. We kind of modify the protocol based on what the client wants. So for example, if they want to chat the entire time they're using the substance, we'll chat with them. If they want us to be quiet and keep them and be a bit more private, they'll use their substance, and we'll check on them every minute to 2 minutes. We'll try to listen on them, see if they're breathing, hear if they're breathing. It becomes very much an art in this sense. And we also offer them additional supports if they want it towards the end. If they're unresponsive, we are asked to call 911, or we do tell them we're going to potentially call 911. In rural communities where this is a bit more difficult to do, we do create a safety plan with them. Or if there's, say, bad weather in Halifax, for example, we'll create a safety plan around with them so that they can get someone that they care about, that they love on the phone, who can help resuscitate them if need be with an naloxone kit. Things we tell our clients to do while they use the line is to keep their porch light on, keep their pets away, keep their front door unlocked, and hide the paraphernalia in case the police come. Um, Really, the mission of this project is to create a national overdose response service to support all Canadians and Indigenous community members that use substances alone. And again, we're trying to mitigate the risk of overdose fatalities. So some barriers that the service removes includes geographic distance for clients who do not want to use supervised consumption sites or have difficulties reaching them. We try to remove the barrier of stigma because many clients don't want to be seen at supervised consumption sites. And we try to remove time barriers as well. So because some of our supervised consumption sites throughout the country are only operating for limited hours. They close down at midnight, for example, and open up at 8 a.m. And so we're trying to provide a service for individuals who are using outside of those hours. So some of our target populations include people who are using substances alone, English and French speaking individuals, urban, suburban, rural communities, and blue collar workers, Indigenous communities. Other individuals who may benefit from this are frontline workers and providers, community providing agencies or community-based agencies, and families of individuals who use alone. Because as a provider myself, I don't want to see my clients using alone, and sometimes we feel helpless because we can't provide them with resources when they are using alone. We are operating across all 10 provinces and 3 territories in Canada. We do know that there's some appetite for this. So Jane Buxton in BC and Vancouver had done this study in which she found that 68% of substance users out of her group of 30 that she interviewed or were willing to use a virtual supervised consumption service. 43% of them did prefer to use alone on the majority of times, and 80% of them reported using alone over the last 7 days. 20% of them said they feel safer using alone than with others. 53% reported saying that that convenience was a significant reason as to why they were using alone. And so this data reaffirms as to why we were trying to provide this service. The service operates from a trauma-informed framework. Our phone line operators are well-versed in mental health first aid and mindfulness training and trauma-informed care. We provide emotional support and overdose debriefing through our virtual staff room for our operators. And a lot of mindfulness support as well. And we're in constant communication with them as this line runs. I mean, they're constantly messaging me, asking me questions. I've had to come in and provide support as well to some clients over the line. Some key pieces of the program is that dispatch services throughout the country are interconnected. Right now, as it stands, 95% of the Canadian population will get support if we call 911 because 191 service, say in Hamilton, can patch over to Vancouver for a call out. We've got some liability support as well, but the big secret sauce here is it's peer run and peer driven. So it's really run by the peers of Grenfell Ministries, the core group of 5 that we have that run this service. Out of them, 3 of them are people of lived experience, and they really are driving the driving force behind the project. So our key goals for the project is to improve people's experiences, both the patient as well as their families. We were hoping to provide supports for providers as well. We're hoping to sort of determine the financial feasibility of this project as well. And overall, again, we're trying to reduce mortality rates in suburban communities. I mean, these are some key pieces of information just that you can know about. We do collect the first initials of the first name and first 2 initials of the last name, the date of birth. We do collect the address of the client, which is promptly deleted after the call is done. We ask that they share with us the substance that they're using and the route because it helps determine when we predict an overdose might happen. And we try to create safety plans in case the client doesn't want 911 dispatched. So yeah, we're hoping that people like yourselves who are listening to this talk can provide this number and website to all the clients who might be using substances alone, tell them about how to use the service and how it works, and encourage them to not use alone where as well possible. Again, the gold standard is a physical supervised consumption site, but we know that isn't appealing to everyone. These are different places that you can dispense this type of information with. We're asking all addiction services and all healthcare services to provide this resource, but it's not just limited to that. It can be family and friends, physicians, outreach workers, pharmacists, police and corrections workers, anyone, really. There are some limitations to this. And I really want to highlight this. Some people might be drowsy and are not necessarily overdosing, but we may potentially cause emergency services to be dispatched to them if they don't respond to prompts. There are some jurisdictional issues as well. Sometimes the police might come out to these call outs, which can be problematic if there is a warrant for these individuals' arrests or if they have children on site. The Good Samaritan Act does not protect them from this. Paraphernalia might be confiscated. And since some people can overdose quickly and emergency services may not arrive in time, like these are all issues. We can't be everything to all people. So these are limitations of the service that we try to make our clients aware of. I'm starting to realize we're running out of time. So I'm just going to skip over these slides, but we not only have our service provisions change from a clinical perspective, but a lot of the treatment services that exist in the community have also pivoted. So they are also providing some education. There's been changes to food handling, food dispensing services, but a lot of these residential treatment services have had to sort of pivot to online resources and provide online resources for their communities. There's been a huge shift towards online meetings for 12-step programming. So that's something that we are advocating for many of our clients, that they use 12-step programming online if they have online or access to online services. So Alcoholics Anonymous is online now, Cocaine Anonymous is online, Narcotics Anonymous as well. These are some different resources that have also pivoted to being online. So Smart Recovery has pivoted to online. AA Sober Living has been always online, has been provided more and more resources for community members. These are some other resources too in the rooms. The Daily Pledge has been there too. My Recovery is a resource there. I can share these slides with you guys later on. With less than a minute to spare, happy to talk more about different resources that we have and how we've pivoted. But I'm hoping that everyone is staying safe and being safe out there. Thank you.
Thank you so much, Dr. Ghosh, for your presentation. And thanks for sharing your perspectives and for sharing all those resources with us. So I'm going to go ahead and introduce the next speaker. So our next speaker is Karin Sawarin. I'm sorry if I said your last name wrong, but Karin is an addictions counselor with the Addiction Recovery and Community Health Team, also known as the ARCH team, that is based out of the Royal Alexandra Hospital. So she has been a registered social worker since 2003 and has worked in a variety of settings, including outpatient, acute care, residential, and specialized services. Karin is committed to patient-centered and non-judgmental approaches to support holistic patient wellness and is excited to share her experiences with us today. So Karin, if you would like, you can go ahead and share your screen if you need to.
I do. Just give me 30 seconds here.
Yeah, sure.
I want to be really honest with everybody that I had this absolutely wonderful intention of being able to create this fantastic presentation for all of you. Unfortunately, due to the pandemic and the stressors, if you will, that are occurring in acute care right now, the slides are going to be a little bit minimal, if you will, but I'm hoping to sort of keep an eye on the time. Perfect, 17:30. So 20 minutes, here we go. And obviously I'll be available for questions after the fact. So thank you very much to everybody for having me. I want to start off by talking a little bit about the ARCH team. So the Addiction Recovery and Community Health program is the clinical arm of the umbrella that is the Inner City Health and Wellness program. So there are 3 arms to this program. The first is the clinical arm, which is ARCH. The second is a research arm, and the third is an education arm. And the ARCH team was actually the brainchild of an emergency room physician, Dr. Catherine Dong, who worked in Emerge for many years and would see a similar type of patient presentation on a regular basis. One of the examples I like to use is, so a patient would present with frostbite, and Dr. Dong could treat the frostbite. But what she realized is there were a lot of systemic issues that were contributing to the frostbite. So the patient was homeless. The patient had no access to income support. The patient had no community supports. The patient might be dealing with addiction or mental health concerns and had no idea where to access care. And so she realized that providing that medical treatment was not enough, and there needed to be a more holistic approach to care. And so implemented in 2014, the team, as I mentioned, is a consult service within the Royal Alexandra Hospital, and was developed in consultation with a community advisory group. So it's actually the AWARE group. It's a well-known advocacy group for individuals who use substances here in Alberta, and actually they have sort of a reach all across Canada. And so they did a lot of consultation, reaching out to patients and to heavy users of service to really ask, what is it that you feel that you need? What are the barriers to getting proper care within an acute care setting? What are some of the marginalization issues that are common? What are some of the biases and stigma you face on a regular basis? And how would a consult team that is really committed to holistic and collaborative care make changes? And so the team started off very, very small. In the beginning, it literally was comprised of a handful of physicians, one peer support worker, and an admin staff, and one social worker. And over time, it has expanded exponentially. So in addition to the physicians, we have nurse practitioners, addiction counselors, the peer support workers I mentioned, social workers, pharmacy, and then an entire nursing component that looks after our supervised consumption site. The Royal Alexandra Hospital is actually home to the first acute care site within North America, which opened a couple of years ago. And so we have nurses running our SCS, as well as we have 18 hours a day. God, I hope that's right. We have an RN actually located in the emergency department of the Royal Alex. And the purpose of that role is to sort of screen and identify patients that would be a good fit for ARCH. So obviously the team does operate very much under a harm reduction philosophy, and we really do prioritize ensuring the patient voice is heard and that they are recognized as the experts in their life, in their situation. And we want to collaborate with them to make sure that their needs are getting met. And also that we're looking at things from a trauma-informed approach and also from a place of cultural safety. So the team does recognize that a disproportionate number of our patients are Indigenous, and we have awareness of the fact that a lot of this stems from historical trauma as a result of colonization. And so we want to make sure that we take all of that into account, and we recognize that, well, yes, the team is functioning under a medical model to an extent, that we want to make sure that we're very, very sensitive and aware of how traditional practices can really complement that medical piece. So just a little bit about addiction counselors in general. A lot of times people don't have a lot of experience working with ACs. The vast majority of them actually work in outpatient settings. And so there is a place here in Edmonton called Addiction Services Edmonton. It's located downtown near the Churchill Square. And that I always sort of refer to as like the hub or the mothership of all the addiction counselors. We do have sort of satellite offices in around, so St. Albert, Sherwood Park, Stony Plain, et cetera. But really the big concentration of them are located out of Addiction Services Edmonton. And it is what we call sort of outpatient services, meaning that patients pre-pandemic could present at the office Monday to Friday and get connected with an addiction counselor. The site was running a vast variety of outpatient programs, ranging from sort of little 2-hour sessions all the way up to full day programs that would run from, say, 10 in the morning to 3 in the afternoon. Unfortunately, because of COVID-19, a lot of those services have been discontinued or they've been changed to a virtual format. And I'm going to talk a little bit more as we sort of go through just about how that has sort of impacted access for patients. So again, just a little bit of sort of fun facts about ACs. These are very, very important things to note when working with addiction counselors. Really, you give me coffee, you can pretty much get me to do anything. And so that's a very important thing for our physicians to note in an acute care setting. So again, what does acute care look like during a pandemic? So for our patient population, one of the big things, and Dr. Ghosh really did touch on this, is it's sort of that idea of isolation. And for a lot of patients, they are sort of lacking supports in general, or a lot of their supports are really informal or street supports. And for patients that are dealing with medical concerns or they're dealing with substance use disorders and are presenting to an emergency department during the pandemic, their informal support network has been vastly diminished. Meaning that, for example, for a female patient who maybe has a partner and it's that partner that typically injects her, and this is a scenario we see quite often, because of visitor restrictions, because of the pandemic, because of a lot of the units being either on lockdown or on watch, that vastly limits the contact that that individual can have with that outside support. So what we see a lot is an increase in patients leaving against medical advice, meaning that the supply that they once were able to obtain quite easily through visitors or through friends, et cetera, or being able to just sort of leave the hospital for periods of time and return, those pathways have been significantly diminished. And so for a lot of patients, if they're not having their needs met in hospital, meaning if they're experiencing withdrawal and they don't feel that their withdrawal is being managed appropriately, or another scenario that we see quite frequently is that patients who are dealing with chronic pain issues, but are also experiencing concerns with substance use disorders, there are tendencies within acute care for these types of patients to be dismissed or to be labeled as drug seeking. And so if patients are not experiencing appropriate pain control, they will often leave the hospital in order to access street supply. Another one of the things that the ARCH team actually has implemented within the Royal Alexandra Hospital is a managed alcohol program. And so for patients that are dealing with severe alcohol use disorder and have expressed no interest or an unwillingness, or just simply it's just not where they're at to abstain from alcohol, we are able, rather, in certain cases, to be able to offer prescribed alcohol to these patients in a controlled setting. And it is, pardon me, dispensed much the same way as any other type of medication would be dispensed. And we have really good data to support the fact that it does actually reduce the number of patients leaving the hospital against medical advice. The other piece within the hospital is, of course, the supervised consumption site, which has been very, very well received by patients. However, one of the things that we're seeing quite a bit, and again, Dr. Ghosh spoke to this, is the fact that there is a big reduction in patients being able to access the SCS. And the reason for that, again, is that they don't actually have substances that they're able to use within the site. And so patients are engaging in behaviors that are certainly much more unsafe, i.e. they may be sharing supplies with other patients. They may be deciding to get small amounts of substances and not wanting to let staff know that perhaps they snuck out or they had somebody somehow sneak something in. They're deciding to use in their room, or they're deciding, again, to leave the hospital against medical advice to be able to go and use in community. And that, of course, does increase morbidity and mortality for these patients. The other piece that we are dealing with, and I'll get to this in a couple more slides, are concerns around supply and the safety of the supply. So acute care, really, for the patients that ARCH services, the pandemic really just has been a complete game changer for these patients. They're used to having less than stellar experiences within acute care. They're very, very used to relying on informal supports, and sometimes really, even if they do have connection to formal supports, like, for example, outside of Addiction Services Edmonton, they actually have a program called Enhanced Services for Individuals and Families. And this is a group of counselors that are actually really more patient advocates, and they're able to go to different sites or go out into community and visit with patients and really advocate for and make sure that their needs are being met. However, this is a service that in a lot of cases, or for a lot of the pandemic, they just haven't been allowed in. And so that, again, really, really limits the amount of contact that patients are able to have with those outside supports. In terms of some of the online and virtual options that are available, they're absolutely fantastic for patients that do have the ability to connect with technology. Unfortunately, for those patients that don't have cell phones, they don't have homes, they don't have tablets, et cetera, that, again, is another layer that limits the amount of support that patients are able to access. So again, trying very hard to put a little bit of data in, because working with a lot of nurses and doing presentations for nurses fairly often, I know that sort of some of the stats and some of the hard data is really very interesting. But sort of to echo the last presentation, yeah, there were some changes sort of right in the beginning, but really what we're seeing is a vast increase in unintentional opioid poisoning, a lot of increased deaths related to fentanyl, a huge increase in emergency department visits, EMS responses, but that decrease in SCS visits. And a lot of that ties into the reasons that I've explained. For a lot of the community services, because of social distancing, they're having to limit the number of patients. There have been challenges within the community with staff being ill and unwell, and at different times not being able to staff properly. Arch is certainly not immune to that. We've had lots of time where we've not been operating at a full staffing component because of either potential exposures or because of active infection due to COVID. And so it really has at times influenced the extent of the care that we're able to offer. The more diminished our staffing component is, of course, the more stress that puts on the remaining team members. And unfortunately, in the course of a day, there simply just are not enough hours in a day. So if you have 15 or 20 patients that you're following, you're not necessarily able to see all of those patients every day. And so at times, patient needs aren't being addressed in a timely manner. And again, that can contribute to poor health outcomes for these individuals. So just a little bit of information, and I think that this really does reflect well some of the patient perspectives for the patients that I'm working with. That loss of connection, the isolation, the fear, et cetera. There's been a lot of concern about supply, and a lot of that has to do with sort of word on the street, if you will. This is what I'm hearing from patients more often than anything, is that they're really anxious to get connected to opioid agonist treatments because of the fact that they're aware of the fact that the street supply is very unsafe. A lot of them have different sort of theories as to why it is, but we're seeing a lot of, because of changes to availability and borders, et cetera. And like I say, we're coming up to that. It has made things much, much more unsafe. So it's really been challenging to try and support patients in a meaningful way. Now, in addition to, and I wanted to just sort of focus on Edmonton proper, when it comes to access to opioid agonist treatment. So for patients that are saying, you know what, I'm really afraid of what's going on, I really want to connect with OAT. So these are sort of the primary places for OAT. The one thing I didn't include was actually the IO program here in Edmonton. Not that it is not incredibly important, but at this time, we're not able to initiate new patients on the IO program due to the potential for the program to be discontinued. We're really hoping that there's going to be some change to that, but at this point, we're having to stick to other types of support. So either methadone, Suboxone, SROM, which is slow release oral morphine, or Cadian therapy. And these are all services that we are able to initiate either during an inpatient visit, or if patients present into the emergency department, we are able to see them in our transition clinic and initiate them and follow them until they're able to connect with one of the programs in community. So all of these programs, and these are sort of the primary access points for OAT in the city. Having said that, there has been a huge increase in the number of general family doctors or general practitioners that are open to prescribing Suboxone. We are seeing a few different, I'm going to call them private clinics, that have popped up that are looking at providing OAT services simply to reduce barriers for patients. ODP, for example, does have a few satellite clinics available. So they have something sort of in the south, they've got something over in Sherwood Park, et cetera, just to try and look at what are some of the barriers to patients being able to access care. The other thing, or the other program rather, that we work quite closely with is the virtual opioid agonist treatment program, VODP, that is able to access, or rather provide services to patients that are unable to access care within an urban center. So they're living in a very, very isolated community, and they're able to provide virtual services for patients. Again, some of the challenges is that with the increased number of patients trying to access service, that of course means that wait times can be extended, et cetera. Certainly we are looking at, or rather the programs, I should say, are looking, as are the ARCH team, looking at doing what we can to provide delivery services where appropriate, to look at being creative in the ways that patients are accessing their OAT. But in some cases, It just simply is not enough. If you've got a patient that doesn't have a home, or they're very transient, or they're just not sure where they're going to be next Tuesday, it can make it really, really difficult for them to be able to maintain on the program. The big three in terms of detoxification services, so ARC, the George Spady Detox, and the Complex Medical Detox located in the Royal Alexandra Hospital. So ARC and CMD are both medical detox facilities, whereas George Spady is more of a safe place for patients to go for very uncomplicated withdrawal. They're not able to offer pharmacotherapy of any type. Unfortunately, with both ARC and George Spady, they've both experienced periods of time where they've been unable to take any patients whatsoever due to COVID-19, which again has put patients at risk that are really interested in connecting with this type of service. There just simply have not been the options. With the CMD service that is located in the Royal Alex, it is only a 6-bed unit. And so competition for those beds is absolutely at a premium. Contrary to some opinion, Arch actually is not responsible for admission to that. It is the emergency department and the physicians that are on there that make the decision as to whether or not to recommend a patient to be admitted to CMD. But unfortunately, again, because of the small number of beds, a lot of times those beds are full. So some of the reasons as to why we're seeing all these concerns with supply. So again, business closures and physical distancing and all of these types of things. And so unfortunately, between increased prices, in terms of looking at how unsafe supply has been, we've had a lot of unintentional overdoses come through the emergency department in the last little while. Patients that feel that they have acquired a particular type of substance and something that they feel that they have tolerance to. And unfortunately, when we do a urine drug screen when they're admitted to hospital, they find out that what they thought they were using was something completely different, or it's containing very harmful or toxic substances. And so again, for patients that are saying, you know what, enough is enough, I really want to get into a treatment center, I really want to look at making some changes in my life, because of all of the restrictions on being able to access care right now, it is putting these patients at increased risk. So in terms of treatment centers throughout Alberta, there's a vast number of them that are operated by Alberta Health Services. However, again, quite a number of them have experienced outbreaks at different times, and they've had to either sharply reduce or completely shut down their admissions. We also have a number of centers that are run through NADAP, which is the Indigenous Addiction and Mental Health Service throughout Canada. However, they've had some of the same challenges. Another one of the barriers that has occurred is that because of social distancing requirements, et cetera, some of the centers that would normally accept patients, for example, on opioid agonist treatment are saying, you know what, we're not able to take patients that are receiving daily medications, et cetera, because we simply don't have the ability to get those medications to the individual. So that again is yet another barrier to patients wanting to access addiction treatment. What are some of the big things? I mean, what can we do to support patients during a pandemic? I mean, I could probably talk for an hour about what are some of the things. And really the big thing is systemic change is what's needed. So one of the things that I'm seeing a lot in the hospital right now is because of the fact that we're dealing with a pandemic and bed space is absolutely at a premium throughout the hospital, is there is a huge push to get patients in, to get them as well as possible, and to discharge them. The challenge is where are we supposed to discharge these patients to? So we do have a center here in Edmonton, operating in the sort of same building where the Shaw Conference Center is, so the Edmonton Convention Center. And this has been set up as a temporary shelter for patients. I'm working with a young lady right now who went there, when would it have been? I guess mid last week. She didn't have any place else to go, and she thought, okay, you know what, this is going to be okay. And within 24 hours of being there, she was actually stabbed by another person there in the eye. And so now is on an ophthalmology unit awaiting surgery tomorrow morning. Now, the big question is where do we send this young lady when she's discharged? The word that we're getting from her MRP, or most responsible physician, is that she'll have her surgery tomorrow, and on Wednesday, they'd like her to be discharged. And what do we do with that? And so it's never a matter of not wanting to do the work. I mean, for the social workers that I work alongside, for the patients that I try to support, in terms of connecting them with social work or trying to offer options, you know, maybe it is recovery housing. And again, they're experiencing outbreaks as well. There just aren't sufficient beds. There aren't sufficient programs around. Some of the programs will not accept patients on opioid agonist treatment. Some patients are for females only. Some patients require that you go to residential treatment before you are admitted. What do you do with that? In terms of sort of temporary housing options here in the city, there really isn't anywhere near enough. If you're dealing with a patient, or rather I should say working with a patient who is dealing with any type of complex health concern, so perhaps there are mobility concerns, perhaps they're in a wheelchair, perhaps any of these types of things adds about 5 more layers onto, and there simply are not enough of these types of housing options available in the city. And so these are the types of patients that are often discharged to unsafe circumstances, and then the cycle continues. And so it's not a matter of the team not wanting to do their best to set patients up for success. And it's not a matter of hospital staff at times not being very well-meaning and saying, you know what, we want to put a treatment plan together for you. We want to put a care plan in place that is going to really support your goals, et cetera. But when that service doesn't exist, what is it that we do? So from my perspective, what I see a big part of my role being is to sort of advocate for really compassionate care across the board, to really help allied healthcare professionals to understand all of the systemic barriers that are in place, and how we need to be a voice to say, you know what, this is great. You want to get a patient out of here. Where are they supposed to go? You don't want them to be a heavy user of service. You don't want them to continue to present to the emergency department. But if that's the only place that they feel that they are safe, and I mean, that's a fairly relative term when it comes to a pandemic, any patient that is admitted to hospital right now for any reason is really putting themselves at increased risk. Where are the safe places to place these patients? And so with all of the different restrictions and all of the different factors that are contributing to ongoing social isolation and marginalization, where do we go from here? And it's a question I ask myself a lot. It's a question our team is really struggling with. And so hopefully by really creating a strong voice for advocacy for this patient population, we can improve things for them long term. And just a little bit of happiness right at the end. And obviously we'll take questions after the last presentation. Thank you very much.
Thank you so much, Corinne, for sharing that presentation, as well as talking about some patient perspectives. I think that was a very valuable presentation, so thank you. I'm going to go ahead and introduce our last speaker. So our last speaker is Lawrence Wu. Lawrence is recently graduated from the U of A with a degree in pharmacy. During his undergrad, he worked inner city and also completed one of his electives with Arch in Calgary. He currently works with Mint Health and Drugs downtown Edmonton, first as an intern and now as a pharmacist. He has worked throughout the pandemic servicing the Edmonton isolation facility. Lawrence has also worked closely with the George Spady Detox and numerous organizations that provide emergency shelter and transitional housing to vulnerable Edmontonians. So Lawrence, thank you so much for being available on such a short notice as well. If you have any slides to share, then you could go ahead and share your screen.
Can everyone hear me? Yeah. Thank you so much for having me. I don't have any slides prepared. And even though it was a short notice, it's an incredible honor to be part of this panel, especially as such a fresh grad. But I have been working in their city for about 4 years now, and I've been working throughout the pandemic since March. And so I was thinking about what to share today. I know that there were some prompts, but I kind of thought while I was working throughout the day, you know, what has changed since day one of the pandemic, or when it was announced as an outbreak, and what kind of things have we done as a pharmacy team, or how have our partnered facilities and organizations adapted to increase accessibility and resources? So I think my talk will primarily just focus on 3 main points: the accessibility portion, the resources, and the scope of pharmacy practice that's changed. So COVID has really accelerated advancements in technology and remote monitoring and whatnot. And a lot of our patients, unfortunately, being in the inner city, don't have access to those resources. And so one of the main barriers initially was getting medications to the patients. when the crisis happened, there were different organizations that all worked together to have isolation facilities, different measures for transitional housing. And some of those examples would be the isolation facility that was at first at the shop, sorry, not at the shop, at the, what is it called? the expo center. And then later, later we would actually take on another project, Coliseum Inn, which is very close to there. And then I can name like probably 6 on the top of my head now. So there's the Edmonton Convention Center, Salvation Army, CESCO, Jockey Dorm. So there's a bunch of organizations that were working together to help these patients. And one of the main barriers initially was that a lot of these medications required witness. So it was very difficult at first when we would receive a prescription for, let's say, Cadian that required witness. It's just a slow release oral morphine. And it's one of the opioid agonist therapies that are an option, and it would be open a capsule, but there wouldn't be a healthcare provider there to provide it. And it was really unfortunate that this was the case for a lot of things. But eventually, nursing developed protocols, procedures, and we removed those barriers by allowing nurses to be equipped to handle all these medications that were coming in. And so another thing about accessibility that Dr. Gosh talked about was the exemption for narcotics to be transferred. So this has been something where has been very beneficial for a pharmacy practice, especially when a patient might be discharged to the isolation facility, but then they would be then transferred to the Salvation Army. And as pharmacy care providers in the inner city, there's a lot of transferring medications around, and reducing the gaps in care are so important to help increase the patient's engagement in care. Whereas a lot of times it's very difficult to say that your medication can't arrive today. You're going to have to go into withdrawal for a day, something like that. Another thing that I've seen a lot is the virtual opioid, the VODP, virtual opioid dependency program, sorry. And they've been an amazing resource in actually just starting people same day on opioid agonist therapy. So initially there would be quite, I think, like initially when we received these prescriptions, so basically an opioid dependency program that's virtual works out of Panoka, and they're able to start patients on therapy right away. And prior to this, it would be very difficult to connect patients to care oftentimes at such an advanced pace. Unable to, a lot of people were lost to follow-up. They weren't connected to their family doctor. They didn't have a primary care provider. So to be able to do this was amazing. Another part of accessibility is from anyone here in the pharmacy and also medicine field that Suboxone and Methadone no longer required coverage. So that was a huge win in order to get people started therapy, because without those financial resources, patients often are not able to pay for these medications, and that just removes another barrier. Another thing is a lot of red tape was kind of eliminated. We used to have to call for a lot of prior approvals and whatnot. And from the pharmacy perspective, this really delays care. It could take a day, it could take a couple days. And for instance, when we would, call NIHB, which is Indigenous Affairs, for prior approval for a certain medication, oftentimes letting them know that they're in isolation really helps speed things up. Another thing that has really helped in terms of help advance the delivery of healthcare is one of our collaborations with an outreach nurse. So the outreach nurse does work for us, and as you might know, a lot of patients who are on witness therapy have to show up at the pharmacy every day. And that's a huge barrier in COVID, during the COVID times, especially during the peak of the pandemic. It was very unfortunate to have to ask patients to stand outside in the cold. We have a very small space. And when this happens, when patients who come to see you every day are very, I guess it's part of their day. It's them interacting with someone, and it's great conversation. But by rushing individuals, by asking them to stand in the cold, it was very difficult, right? And because everything just became so, I guess, there was no connection anymore. And a lot of patients, we actually had to end up turning a lot of patients away who we just didn't have the resources to actually provide daily witness for all these patients. And we just thought that they would receive better care elsewhere. We spoke about deliveries, and that's also another thing where when we're delivering all these medications every day, that aspect of human connection is also something that disappears, right? And not being able to follow up in person is something that I definitely can relate to in terms of patients not being as engaged and not being able to follow up on things as closely. So one of the projects we worked on was the Coliseum Inn, and I don't have any statistics here, but there have been quite a few increases in overdoses, unfortunately. And so, the team at Coliseum Inn that partners with, I believe, Streetworks and Homeward Trust actually do check-ins on the residents' rooms. So that's like a part of being able to connect to a patient and in ways that the pharmacy team can't. And having this outreach nurse that's able to bring these medications to patients to witness it has been such a huge plus, because that was definitely a really big barrier in patients accessing care. Another aspect of collaboration is the mobile integrated healthcare team, and they're called MIH, and we've actually consulted them a couple times. There's some community paramedics that are able to actually help us draw blood cultures, have a physician on call to assess cellulitis, something like that. So being able to learn the different resources in the inner city as a pharmacy who's termed the most accessible provider has been very beneficial, especially when there's so much, there's just so limited scope in what pharmacists can do. But that being said, we also hear about all the different things. And so, by branching out, by collaboration, that's been a big part of helping individuals beyond just medication therapy. And that's probably one of the best parts of, working my job, being able to work with all these different providers. So I'm going to answer some of the questions that were prompted to me. Just let me take a look here. So explain OAT management programs and the impact you have seen seen it have on patients. So I think the technology of being able to bridge people on therapy in the same day, fast start Suboxone, we used to see 12 milligrams a day first day. Now we're seeing 16, no witness. So just really reducing those barriers, really balancing the benefits versus the risks, and helping individuals really connect with care right away. Like, no joke, I call them at New Year's Eve and there's a Suboxone prescription in my fax machine in 5 minutes. And this really is really beneficial for a lot of patients. And I'm really glad that there is something like this in Alberta. What are some various harm reduction strategies that you can incorporate into practice? We work with a numerous amount of transitional housing and high-risk youth. So a lot of our education is actually centered around equipping staff members or caseworkers and whatnot to have that conversation about harm reduction when someone might be mixing alcohol with a benzodiazepine or using fentanyl on top of methadone. Like, having that conversation on what are the risks, what to look out for, and also supplying naloxone kits, naloxone nasal sprays, which has been a really big part of our initiative in helping with harm reduction. How has COVID-19 impacted your practice? I guess I did answer this question, but it's really nice to, again, reiterate saying that all these gaps in care are being managed, from everyone's understanding that there's more and more barriers and what we can do to cut down these barriers for patients. And so seeing that progress has been really great. Lastly, what are some action items that we as university students can take to address the opioid epidemic? I think for people in the healthcare background and anyone understanding or educating others on some resources, it's often so difficult to do things alone, right? And to collaborate and to educate others and have that conversation is a really great resource. modeling that behavior of harm reduction and showing compassion in everything you do. I think that's another really big emphasis point. It's really hard to say you can't do something. I don't have the time, I don't have the resources, but with such a big team, and knowing who is able to step up to help, that can really help, solve those frustrations and find a way to help patients. And lastly, like modeling that behavior in your community, in the conversations you have with others regarding harm reduction. I think that oftentimes, there's such a different perspective, whether you're in acute care or community, on what harm reduction is, no matter where you work and what setting. And working in inner city, you get so used to, preaching it. But sometimes when you step out of that, you realize that not everyone might have the same perspective, and maybe sharing that with others is really beneficial. So that's all I have prepared. Thank you so much for just staring at my screen. I apologize I don't have any slides, but it's been a great honor. Thank you.
Thank you so much, Lawrence, for sharing your ideas. That was a great presentation. And yeah, just thank you again to all of our speakers for your insightful and valuable presentations. It's really appreciated, and thank you for taking the time out of your day to be here. So I guess now we will open the floor for questions. So you can either do this by unmuting yourself to ask a question, or you could type your question in the chat. You could ask a general question, or you could direct your question to a specific speaker. So when you ask a question, just please indicate who you are directing your question to. So I'll take a look at the chat and see if there's any questions coming in, but anyone, feel free to unmute yourself and ask any question.
No one ever wants to be first.
If you want, I'll ask a question, and it's going to be a question I've already asked Monty, so I know the answer, but it's a good conversation. Sorry. Monty will give me a hard time later. Monty, talk to me about the duty to warn and the impact of what happens if I, as a mother, call and use NORS and you guys hear a kid on the phone. How does that work? Because it's one of the tricky parts, right?
Absolutely, it's 100% one of the trickiest things that we've had to deal with, and you hit it on the nail right there. Like we really have to warn our clients. It's something that we have to tell them. We do it confidentially. As a physician, you have to keep some of these things confidential without knowing too many details. Because if you know too much, then that's a problem as well. Just asking them, if you hear a voice on the other end that's a child, you have to tell them that there's a potential risk that protective services might take their kids away from them, that they might get involved in the case. And then these are very difficult for patients and for individuals. I call them patients because that's what I'm used to using as a language, but for individuals. The one thing that I really want to advocate for, though, is that we need to change the Good Samaritan Act. I personally feel we need to broaden the scope of it. So we need to stop restricting people who have warrants for their arrest or for people who have children. We need to encompass them in the act. It's not directly mentioned, but because it's not directly mentioned in the act, that poses a problem because it can be interpreted any way that people want, really. The fact that paraphernalia might be confiscated, it's not even mentioned in the act, but like people, that does happen. We hear it from our clients all the time. So that's the one thing I really want to stress. I mean, from an addiction physician perspective, and Corinne, feel free to jump in on this too, because I know you have some experience with this. But I try to keep families together. We know that adverse childhood experiences can be very impactful for multiple generations of individuals. And a lot of the cycle of substance use is passed on from generation to generation, right? Through intergenerational trauma, through repeat harms that we do by separating children from their parents. And that was the way we used to operate as society back in 70s and 80s. And that is not the way we should be operating as society now. We have to try to keep families together, keep their support structures together, try to support the family as a whole. And that means individuals as well as the entire family, of course. And we need to move away from harms of separating them. And so, yeah, this is a very difficult conversation, but it's a conversation we need to have. And it's a conversation we need to have with each individual who's on the line for NORS, that they need to be aware of these consequences. And so if they choose not to use the service, it's totally acceptable. And then many of our clients would rather sadly risk the harms of overdosing on their own, which I think is more traumatic for children, if like facing death of a parent, than risk their child being taken away from them. Shay, what are your thoughts? Do you want to throw in a little bit about this?
That's mean-spirited. I'm not supposed to be talking. The reality is that the duty to warn related to children being in danger of somebody using drugs does not mean they're bad parents. There's nothing in my urine that tells you I'm a shitty parent. Hearing a child in the house when I'm trying to prevent overdose, that's a good thing. It means we're all being open and the child is being, well taken care of. So I would say that along with the automatic police response that happens in some communities to specific addresses or as part of the culture in Alberta, is incredibly detrimental to healthcare, and to people trusting professionals. I'll get off my soapbox.
No. Like I'm just over here like doing the little, yeah. I mean, I'll try and keep this brief so I don't go off on a tangent, because this is another one of those things that I could probably talk about for an hour. So there's a few different things. I mean, one of them is that we absolutely know that in terms of women wanting to access recovery services of any types, there are multiple layers of barrier in there, and a lot of it revolves around children. And women's roles within the home and et cetera. But we make a lot of judgments. And a lot of it, unfortunately, even now is due to culture or due to race, that if there is substance use present, that person must be an unfit parent. And I have actually really struggled with some of the language and some of the treatment that these women experience on the women's care units over at the Alex. One of my favorite statements, when you'll have a young Indigenous mother there and she's pregnant and maybe there are concerns with substance use and maybe there are mental health concerns. And I will have nurses at times say, you know what, we shouldn't have to deal with patients like this. And my response to that is always, I'm sorry, do you mean pregnant patients? I thought that's what this unit was for. And unfortunately, there are a lot of assumptions that are made because of last names. For our Métis patients, there are assumptions made because of the color of someone's skin. There are assumptions made because of the number of pregnancies an individual has had. Quite honestly, it's stigma and biasy that for myself as, a white cisgendered woman, if I was there, I likely would not experience that. For all anybody knows, I'm at home killing 2 bottles of red a night, but I don't fit that profile. And we make these assumptions. I dealt with this a lot when I worked for ODP here in Edmonton. I was there for just about 11 years. And a lot of times women would be terrified to start on methadone because they were convinced that that would flag them with children's services and it would be an automatic, I'm going to lose my children. And we did everything that we could to teach, and actually more often than not, it spoke in a positive way, and it actually helped to maintain families. But we are so big to pass judgment on families, and we are so big to use one lens, and that really is a Western colonial lens, and that is the only thing that constitutes a family, is what colonial practice tells us. And if it is if it's a family that adheres to more traditional beliefs, nope, that's not okay because it doesn't fit this mold. And it really is one of the huge things that contributes to families being absolutely torn apart. It's completely contrary to the idea of reunification, and it absolutely contributes to deficits and social determinants of health. And it just perpetuates generation after generation of trauma. I don't understand how we can expect these young mothers to be able to parent when their parents were taken away from their parents and those parents were in residential school, etc. And year after year after year, we just keep making the same mistakes. And if we could take some of this focus and actually look at creating a children's services component that actually was focused on the strengths as opposed to the perceived deficits within families, and look at supporting that self-determination, look at, you know, this mother wants to parent. Let's not focus all of our energy on apprehension, but how about looking at what additional community supports can we put in place? What family support workers can we have there? How can we help her to parent? And how can we help to keep that family together? And I'll get off my soapbox now. I just, yeah. I don't want to monopolize. I saw a question up here around peer support, and I don't know if anybody has strong feelings about answering it or not, but I do work with a lot of peer support workers. Monty, I'm not well, you do too, if I'm not mistaken. Yes, Monty's nodding. So how have things changed for peer support workers? Well, they're really tired. I mean, I'm going to start there because the breadth of their practice has changed exponentially. I mean, first of all, they really are, in a lot of ways, the people that really help us to make connections with patients that are so afraid of the system and have had so many negative experiences that they're just simply not willing to trust. And so to have somebody go in that has that lived experience and that has that compassionate approach that can say, look, I understand that things have been really horrible. Let me share some of my experiences with you. Let me tell you that these people really are good and they really, really care, and give them a shot. And then, you know, it's on us to sort of prove ourselves and demonstrate that we really are there to support their goals and what they're wanting to achieve. It's not what I think is best for them. It's wanting, my approach is always to make sure that they are making an informed decision. So I will talk to them about, okay, here are the positives of this type of treatment, here are the negatives. Like, let's not sugarcoat this. You know, when I worked for ODP, I didn't get a commission every time somebody decided to start on OAT. I wanted patients to know that, yeah, there's some great things about being on this program, and here are the downsides. And now this was at a time when there were a lot more restrictions. And it was 100% you were daily dosing. And so that's a restriction for a lot of people. There could be cost issues depending on, did the person have prescription coverage? Did they not, et cetera, et cetera, et cetera. So I wanted people to really know this is what you're getting into. It can be an absolute pain in the you know what at times, but here are the benefits, and let's help you to make an informed decision. And so our peer support workers really are the bridge, and they help to get us in the room. We're seeing our peer support workers absolutely go above and beyond and trying to, again, maintain social distancing, but not always being able to do that in their role. Trying to advocate for patients to be able to leave hospital, to get connected with funds where they need to be able to help secure housing. We had one peer support worker actually out of the hospital, I don't know how much, about a week ago, trying to get a patient settled in an apartment. And she's a double amputee, she's in a wheelchair. This was so above and beyond, it was absolutely insane. And let's remember, every single time she's having to go into that room, she's having to do her full PPE, she's having to go through all of that and all of the screens, and they're putting themselves at considerable risk to be able to really ensure that patients are still getting the best care possible. And we're really still trying to look at reducing patients feeling that they have no other option besides leaving hospital. So they're really sort of a linkage between all the different allied care providers, and they really are always there to provide that, I guess, that other side of things. So again, we have the tendency at times to pathologize or medicalize things on that side. And I mean, yeah, there are benefits to that, but there's also that whole social piece, and there's that recognizing that patient-centered aspect of things. And just because this is the textbook way to deal with this, that may not be the patient's goal. And so it's looking 100% at meeting that patient where they are at. And if their goal is not to make any changes to their substance use, great. How do we help you to make the safest choices for you? And so they're just instrumental really in everything that we do. So they're much busier, they're much more relied on right now, and we couldn't do the work that we do without them.
I echo that. So I've been a huge proponent of peers. People lived experience. One of my mentors, Marlis, who many of you know, has been always reminds me that I shouldn't be calling them peers. I should be calling them people who lived experience. And it's hard to not call them that because because the peers themselves call themselves peers. But for me, and this is the word that I hear from many of them, is that if you've walked the walk, then you can talk the talk. And for many of us who've not lived or experienced substance use or problematic substance use, it's so true. Like I talk to my clients and they don't understand what I'm trying to convey to them because I haven't been there. I haven't done that. And to have someone with that lived experience come forward and be able to share and relate to them, it's a much more powerful form of education, of understanding, of like knowing where they need to be and where they need to go in life than anything else. It's like one of the most powerful tools we have out there that we don't take advantage of, I think, as a clinic. I think I do a lot of research around this area, and we do have evidence that shows that it's much more impactful for patients. They tend to listen more to peers than they would listen to people like myself. We know that impacts providers as well. We know that at merge departments, for example, that if you have a peer placed in there, the doctors who might have been very stigmatizing at first to this population group get to understand what it's like behind the scenes. Like they get to understand what substance use is about. They understand that not everyone fits their mold of what they think substance use is like. We know that there's more positive outcomes from this. We know that more people are allowed or gain resources in the community. There was a study that was done in Rhode Island in which people who showed up with overdoses to the emergency department, for example, they would only 30% of them would actually access their opioid clinics in the community. But when you attached a peer to them, 80% of them would actually show up. We see similar results with Hep C and HIV, where there's ongoing treatment supports for these clients with peers. There's more uptake to treatment. So they're a very powerful tool. Many of you don't know this, but we've launched a service in Calgary. They're called recovery coaches, but they're peer navigators, people with lived experience. We've got funding for it for the city of Calgary. We've got 5 now individuals with lived experience who will connect people to different community resources. And they do things like motivational interviewing. They'll do mental health first aid, crisis intervention where needed, and they stick with a client for a year-long period. So it's helping clients transition from service to service to service in the community, whether it's from detox facilities such as Renfrew, whether it's from places like the Arch program in Calgary, to other community resources. It's all about walking with them through the different transitions of their journey. And it's providing them with resources that they need at the time and meeting them where they're at. So a client may not be ready for recovery services. They might not be ready for OAT. So we take them to the supervised consumption site. We provide them some education. They might be ready for housing and income support, but they're not ready for anything else. You provide them that. You meet them where they're at. You meet them where the goals are at, and you determine their goals. And that's the key piece: is you figure out what their goals really are. Because I think a lot of times when patients tell me this, no one asks them that question. What do they want? We tell them what they want. We never ask them. And we got to start avoiding that as a profession. Medicine, healthcare in general is very paternalistic. Hopefully with the new generation, that's changing.
I just saw, Shay, that your statement around peers, and I'm not trying to scroll ahead, but that's the last comment. And I do agree with you. If I could be so bold, no, I'm going to say it. I'm just going to say it because this is my opinion and I'm allowed to have opinions. I think one of the things that we don't do well is, yes, we utilize peer support workers in more and more different facets of addiction, mental health, and different other types of fields and services. What my experience is that we do not do as well as provide them with support, meaning that for myself as a social worker and a counselor, I have peer mentorship that I can access. I have people that have more experience than I do or work in different areas that I can reach out to and debrief with them, or I can go to them with clinical questions or all of these different types of things. But the peer support workers do not have that same type of formal network. And not being a regulated profession, they don't have some of the same things that, say, nurses do. You guys have education that you have to do. Pharmacists have education they have to do. Social workers have education that they have to do. And that helps to keep us, I guess, supported and connected with those outside supports, et cetera. And so, yeah, we do really rely, sometimes putting our peer support workers, I think, in places where it can be risky to their overall health and wellness. And we sort of, well, they'll deal with this. And we don't think about what that means. And we just sort of assume that, well, you know what, they're in this great place and it's going to be fine for them, not recognize that there's somebody that has been on a journey as well. And just like anybody, they're vulnerable to the same types of things our patients are. And so there are times that I've almost seen more compassion go towards our patients than our peers, if that makes sense. And I don't mean that in a negative way that we're being mean to them, but it's sort of, oh, well, they, you know, our patient needs this, our patient needs that. But what about this person that has walked that path to some degree and now is being expected to do, as you put it, the heavy lifting for this individual? Where are their supports? And so I would really like to see that the more we introduce these types of services, the more we become accountable to making sure that they are having voices in creating support systems and different types of learning opportunities and whatnot that help them to feel better equipped and sort of more in control of themselves and their situation, and hell, be able to say no to the doctors at times if it's, you know what, no, this is something I can't do, or say no to me, to say, you know what, Corinne, I'm really sorry, I don't think it's appropriate for me to do that. I think it better be you that goes in and has that conversation. Absolutely. To really empower them to be able to say, you know what, I need to set this boundary, and not feel as though that means people are going to look at them as though they can't do the job. We're able to do that and say, you know what, that's not my role, or I'm sorry, there's a boundary there, or I need to, and that's okay. Why isn't it for them?
Yeah, they're the voice of the patient. I find you're right. It's just they tell me things and they point things out in my head that I just never thought about, and it's surprising. They're like, you know, they like sometimes patients are afraid to talk to us. They don't want to advocate for themselves, so these peers advocate for them, and it's so important. Like I agree, they do the heavy lifting. We need to pay them well. That's the problem that I'm running into right now, is that they're not paid well enough. We don't value their skill set nearly enough, and that needs to change. And hopefully that will in the future. HS, I know, for example, like to get our peers, we had to go all the way to the top to get them even recognized as a new service. And to have a new healthcare worker in a system that's been around for a long time is hard. Like I've had so many phone calls with leadership where they're like, what are you talking about? What are these? What are they useful for? But I think that is changing. I think like the ARCH program, for example, has been instrumental in changing that philosophy that we can't hire people with lived experience. I'm hoping that other programs in the future can use people with lived experience too, and we're seeing that more in like cancer care treatment now. We're starting to see them trickle into more mental health services that we're providing. They're being utilized more and more in different streams. I've got a project with Calgary Police Services coming up right now, using people with lived experience to de-escalate complex situations. One of the things we're hoping for with the emerge departments in our province, especially in Calgary with our peers, is that they can de-escalate situations in the emerge that are violent situations. Usually, like we have data that shows 90% of violent situations that occur in the emergency department are because of crystal meth use and psychosis. And so we're finding the peers what we're evaluating right now is peers being an effective tool to de-escalate the situation. Much better than security, which actually makes the situation worse. Much better than physicians, who we just like to push drugs into people to sedate them. There's an art to this, and you know, it's about taking them to a quiet room, turning off the lights, talking to them as if they're a person, not treating them as if they're, I hate to say it, sometimes an animal. And yeah, sorry, that's me going off now. I'll pass the mic on.
Okay, here, I'll read off the next question. So Amanda asks, since the beginning of the pandemic, we have seen reports of increased synthetic opioids and cannabinoids that are naloxone resistant in the drug supply. From the perspective of healthcare professionals, how can we navigate these challenges?
Yeah, I'll take this one on. So I personally worry about this, and this is all about harm reduction. And I think we've got some big experienced harm reductionists here on this, like not on the panel necessarily. Like I definitely wouldn't call myself an expert in this field compared to others like Kim and Shay. But yeah, like we do see this. We don't know what's causing this. Like if you look at the latest opioid reports, when you look at the people who've overdosed from fentanyl, only 3% of them had benzos. But I fear it's much higher than that. I see a lot of people having this. It's a huge issue for us. How do we navigate the issue is a bit more complex. But we do see more analogs, and it makes sense. So I hear stories that the supply chains are disrupted across the province, but I also hear stories that it's not, and that things are coming through. I personally think that's a mix of the supply chains being disrupted from around the borders, but also the fact that there's been so many crackdowns in China for creation of this drug that it makes more sense for individuals who are in factories creating this to make much more potent analogs that are longer lasting and ship less quantity over, if that makes sense, than what we had before. And so you're seeing it's a scale of economics or economies of scale is what I'm trying to say. So the more potent you have, the more potent the drug is, the smaller amount you need to get the same amount of high. And because of the shutdowns in factories in China, because of the border closures, they need to slip. They can only slip a small amount. So you really want to make that amount count. So that small amount is much more potent now. That can be diluted into into more batches. That can support more of that can supply more of the population. But the concern is that you can't really control the amount that you are adding in each dose, if that makes sense. We call it the cookie dough effect. Like chocolate chips and cookie dough is like chocolate chips are fentanyl. The cookie dough is the substance you use, and you can't predict how many chocolate chips can go into each batch of cookies. It varies from dose to dose. It varies from cookie to cookie. So it's super complex, and these are just theories. We can't prove any of this, and that's important to note. And so for me, and again, I defer some of this to others as well. I believe in universal harm reduction. So we have universal precautions for infections, such as HIV, for example, and for surgeries, we have to wash our hands. We have to do universal harm reduction. So anytime you use a substance, you got to make sure that you're using small amount in a slow way, because you can overdose. To titrate up, if you may. Never use alone, even though you think you might be okay and safe with a certain batch, even though you believe your supplier is providing you with what's usually out there. Use your common sense. Like I hear this from my patients all the time that they'll see a slight color change now all of a sudden. That's a big trigger that you need to be careful with this. It's like that should be that education, and most of them have it. Like, I find that people with experience and people using substances are much smarter than myself. They've been able to pick up on things. Like I'll be honest with you, the Norris Project was from a person lived experience. It was someone who was smart enough to be using the phone line, who was using FaceTime with someone else. This is 4 years ago in Grand Prairie, and this is from the Alberta side of things, who figured out that it was just smarter to use via FaceTime with someone else in Edmonton when they were in Grand Prairie. But again, like these are common sense things that we should be providing. It's universal harm reduction for everyone. It should be an education that we provide to everybody. People use substances at parties, not knowing what they're taking, right? It doesn't have to be someone who's a chronic substance user, but someone who's just a one-off at a party. So universal harm reduction is key. It has to come through public policy. It has to happen in schools. It has to happen everywhere. Yeah, that's what I strongly believe in.
Okay, so the next question is from Jean. What are the panel's thoughts on RAM clinics?
I can take that one because I operate one. I wonder, Jean, you're probably tailoring this towards myself, aren't you? So in Calgary, we have a RAM clinic. It's a brand new concept within Alberta Health Services. We have two now, actually, one with the Alice Community Health Center and one with the AHS. We call it Rapid Access Addiction Medicine. And what it is, it's a clinic that sits outside of the hospital scene. Traditionally, they were part of hospitals, but we're kind of moving away from that, where clients who come in with substance use concerns or behavioral addiction concerns as well can get managed. The traditional concept was from Ontario, which people coming to the emergency department can get triaged to somewhere else and get seen quite quickly for their substance use issues, and then get managed in the community thereafter, get transferred into the community. We're a bit different in our Alberta projects, or Calgary projects, I should say. We sit outside the hospital. We sit with our own version of adult addiction services, which is something that you guys have in Edmonton. There's 9 physicians there. We see clients right away. They come from the emergency department. They come from clinics. They come from the community. They come from shelters. They come from everywhere. And we work closely with the counselors to help manage their pharmacotherapy concerns, manage other concerns such as HIV, Hep C, do concurrent management of mental health issues. We have a pain stream, a perinatal stream. We have an alcoholic hepatitis stream that I run. We've got different streams for different things. We're doing home detox now as well out of our program, which we're hoping to scale province-wide in the near future. It's definitely, I think it's useful. We've in the last 1-year trial of the program, we've had about 800 to 900 clients pass through. So quite a few, and we've got a panel overall combined with addiction services of 3,500. So it's quite a large service now. The Alex has a program similar to this as well. It's a bit of a smaller scale. They operate from 9 to 11 every day, Monday to Friday. And they have a counselor and a few physicians that help support clients. Smaller scale, but the beauty of the Alex is that they really do provide those wraparound services that I feel as adult addiction services we cannot provide as well. They've got access to housing. They've got social workers for income support. And yes, we have those services too at adult addiction services, but I don't think we're as good as it as some of these community-based agencies because of barriers that Alberta Health Services puts in place in terms of roles and responsibilities. As much as I work for Alberta Health Services, I really believe in a lot of the stuff exists that a lot of this should be supported in the community, and the community does a better job at it than we do. And I'm sure I'll get myself into trouble for saying that. But yeah, these are programs that exist here. I know that there's plans for this to come to Edmonton very soon, and senior HS leadership is examining that. But a lot of it depends on what our outcomes are from our clinics in Calgary, which is what we're doing right now. We're sort of evaluating it and looking at different metrics to see what's been done and trying to improve upon it as we move forward. So I think there is an advantage to having RAM programs. They exist all across the country. We need to have more of them. The ODP is a really good example of a RAM clinic for just opioids, but we need to have broader supports such as alcohol, access to methamphetamine supports, quick access to other substances supports as well. So that's kind of what we're hoping for. We call it the ODP for all addictions here in Calgary because a lot of people don't understand what a RAM clinic is.
Just offer a little bit of reassurance to that for those of us who are really, I guess, enmeshed and connected to the idea of harm reduction and really providing patient-centered care. We always follow Alberta Health Services policy to the letter and would never, ever do anything that would circumvent or be considered a workaround for that type of situation. Never.
Okay. So the next question is for Lawrence. So as a pharmacist, are you or other pharmacists aware of the hotline NORS that Monty talked about? Is this something that you can recommend to patients who are isolating?
Thanks for your question, Ash. This is actually the first time I've heard of the NORS program. And I'm going to take this as like an opportunity to learn more about it. But unfortunately, I think that I'm not sure if it's just because I'm a pharmacist and I get to complain, but like sometimes we're not necessarily like, and things are always changing, but I don't think it's within, not a lot of people consider it their responsibility necessarily to go out and seek and learn and be incorporated in all these new initiatives and guidelines. And so this is something that's new to me. I definitely do think there's application in this. When we dispense opioids, for instance, it's always recommended to provide an naloxone kit now and provide a Health Canada letter of warning about the dangers of opioid use. And so for my for my patients personally, I don't think it would be as applicable because I predominantly work within like a population that might not have access to a phone. But you know, the opioid epidemic does not discriminate, and certainly this would be something that's very beneficial. And maybe I'll send that to our college to like send out a mass email or something. I think that, you know, one of my passion projects was, while as a student, was to learn more about these resources. But the more I looked into it, the more there was so much, and it was overwhelming. And I only know two. I only know Access Mental Health right now and VOGP. And that's kind of it for me for now. But I certainly, I think this is incredibly beneficial.
No, thanks, Lauren. And then just to add to that, we actually are talking to the College of Pharmacists.
Wonderful. Thank you.
A few of my colleagues have sort of connected me with them, and we're discussing how to best implement it. There's a lot that's still unknown, right? Because we don't have the data behind it, the evidence behind it, and that impacts the uptake. So much like naloxone kits, right? Naloxone kits weren't widely distributed until there was actual solid evidence that it's effective. And we know now that it is, but it took a while to get there.
I mean, if I could, I guess, be so bold, is one of the things, Lawrence, is that you're not expected to know everything. And so that's kind of how we, I guess, get around this. When you've been in the field for a while and you've worked in different places, you sort of create your little networks. And so you know who the experts are on different things. So, I mean, I have people that work over here and over here and over here. And so if I don't know the answer to something, I know who to call to get it. Or yeah, maybe I'm not aware of every single initiative that's happening at Addiction Services, but having worked over there for a long time, somebody's going to give me a call and be like, hey, did you hear what came out of our staff meeting? And so that's how you kind of pick up on these bits of knowledge. So it's just a matter of creating those networks. Like things within pharmacy, I used to, again, at one point think that I knew everything there was to know about OAT and prescribing and this and that, and things just keep changing. And then there's gap coverage, and then there's this, and oh, SROM, and nope, that's not formulary in hospital. Now it is formulary in hospital. Oh, it always has to be a witness. Oh, no, now we can deliver it. Like it's boggling. And I don't think anybody can be expected to keep up on every possible innovation and you know, the new thing that's happening within every discipline. So I mean, that's really, I think, an excellent way of illustrating why having those interdisciplinary approaches and those teams and those networks of, you know, I'm not sure what to do here in Calgary. Oh, you're moving to Edmonton. You know what? I know who to call, and vice versa. So I think it's just really important. And I think that that's why I really enjoy doing these types of educational opportunities, because it helps to get faces out there and names out there. And I have people that will just email me or call me randomly and be like, okay, you know what? I saw you present at this. Can you talk to me a little bit about what are the services available for this type of patient? And I'm always happy to answer those types of questions. So yeah.
Thank you.
I mean, we only started a month ago as well. So I think.
Yeah, like actually, just to add here, George Spady Detox, we actually have a nurse practitioner now. So we will be doing some more complex medical detox. So that just happened last week.
Okay, are there any more questions? You can put your question in the chat or unmute yourself if you're feeling brave.
I think there was another question from.
Oh, and I've got a direct message.
There's a question from someone that asked to add on to Ash's question about NORS. Is it being utilized at assisted safe isolation sites, in brackets, information being provided to clients to aid in safe use during their isolation period?
That's a great question. Not yet. We know in Ontario they are using it at some of the assisted self-isolation spaces. In Alberta, not as of yet. I work with a lot of the committees who are in the self-isolation spaces throughout the province, and not yet, because they have their own plans that they're incorporating into managing these clients. So it's working for them. The fact that they have people on site to help support them if they're using substances is so crucial. And it's a much quicker response than using the NORS line. But for rural areas, especially such as in Red Deer, such as Grand Prairie, I've had some conversations with their assisted self-isolation spaces about how to incorporate NORS as best possible. But again, we're not a be-all end-all service. And for these particular situations, the concept is to have a care plan, a care strategy that incorporates the staff that are already on site as opposed to EMS and 911 dispatch. So it's working out a safety plan with the site and the clients together. But hopefully in the future, it'll pan out a bit more. I suspect by the time that happens, like we don't really need those isolation spaces anymore, hopefully.
Okay, so Amanda in the chat is asking if we can have the contact information of the presenters. So you guys can decide that.
Yeah, I'll give you guys my personal email address. It's I just sent it on the chat to everyone. It's for those of you who can't see, it's smghosh@gmail.com. It's smghosh@gmail.com.
I've shared mine as well, but I keep accidentally private messaging someone instead. So sorry, Monica.
Oh, and I just did the same thing because I was trying to, I have one question that's in private and I had just sent a message to the person to ask if they wanted me to address it publicly or if they wanted me to answer it privately. So sorry, let me do this again and send my email to everybody. And I can't type. Oh, I've got, hold on here. Please address it publicly. Of course, I'm comfortable. Okay, so I have a private question here that I've now lost because there's a lot of stuff here. It was ahead of here. And it was actually a really good question. Sorry, I'm scrolling. So it was a question in regard asking me if I have witnessed discrimination that Indigenous women have faced when they're accessing mental health services under the premise or assumption that they are using. Are there any approaches to introduce more cultural safety training for healthcare professionals and police services when they are experiencing a mental health episode in community? Okay, I can speak to what I know. I mean, certainly there are a few different teams, if you will, that operate here in Edmonton. Are they 100% rooted in more traditional or Indigenous types of teachings? I can't say that across the board. I think that there certainly is more of a push towards more cultural sensitivity. So I can speak, I guess, from an AHS perspective, that there is mandatory Indigenous cultural awareness, cultural sensitivity training that is mandatory for all AHS staff, which I think is a good step. The Royal Alex Hospital is really fortunate in that we actually do have an Indigenous wellness program in addition to an Indigenous wellness clinic. So the Indigenous wellness program operates within the hospital, and they're also sort of a consult service that comes in to provide a more traditional approach to care and to advocate for patients to have their spiritual beliefs, their more traditional beliefs recognized. They do teaching with patients around historical trauma and effects of colonization, and really help to sort of marry the more medicalized approach with a more traditional spiritual approach. And so it really does beautifully create this holistic wellness for patients. Do I witness discrimination for patients? 100%. There are a lot of assumptions that are made towards Indigenous patients. And in some ways, I feel that our Indigenous women are treated even more harshly. There are a lot of judgments that surround women who are pregnant or parenting or not parenting, or perhaps choose to carry a pregnancy to term and then not parent, or perhaps they're choosing to terminate a pregnancy. The stigma and the marginalization, the discrimination, I'm really very sad to say that it is alive and well. There are a lot of assumptions made about these women, a lot of the really harmful language, none of which I'm going to repeat here, is still used to describe these women. And again, there are just a lot of times where I feel that the approach of the healthcare provider is doing more harm than good. And again, I guess speaking from opinion, what my understanding is from sort of trying to engage in conversations and really sort of to call some of these professionals in as opposed to calling them out, but really sort of to, I guess, engage in those discussions and say, you know, I get that you're really concerned about this situation. Can you help me to understand? And a lot of the feedback I get is that the concern is less about the mother and it is more about the unborn child. And it is this perception that this mother is doing harm to this baby, this fetus. And again, I know that this can be a hot button topic, and I know that for some people this is not a popular view. But something that I was taught many, many years ago as both a social worker and an addiction counselor is, yes, obviously I have that positive regard for all people and all life. But in that moment, it is that woman sitting across from me who is my patient, and she is my responsibility. And I am there to support her choices and her decisions. And it isn't about me, and it isn't about my views. And I think that at times there can be difficulty with staff who have very strong views this way or that way to separate that and know what it is to truly be there in the moment with that person and to remain patient-centered. I'm not there to judge. I am there, really the way I position myself always is as a very humble learner. I recognize that there are things that because of my unearned privilege and because of my social location that I cannot absolutely ever hope to understand. But what I want to do is position myself as somebody that is open to learning. And I see that individual as a teacher and somebody that can help me to understand that perhaps even with the best of intentions, I might be creating or perpetuating harm as well. And I want them to help me to better understand. And I want to understand what does fit for them and what parts of spirituality or more traditional ways of doing things do fit for them. It's also making the assumption that any person who is Indigenous, and perhaps they identify as Indigenous, it's also making the assumption that all of these individuals adhere or ascribe to more traditional teachings. Some of them do very much identify as being Catholics or Christians or other faiths. And so it's any of those harmful stereotypes, and it's perpetuating them. And that just contributes to ongoing harm. So we're looking at years and years and years of trauma, and this trauma is just perpetuated over and over and over again. And we see a lot of mental health concerns and addiction concurrently, obviously. And there are a lot of assumptions made around both, that it's a choice, that it's that, you know, that they're weak, that they're this. I mean, the number of things that I've heard, it is just shocking. And these are from healthcare professionals that are in a position to provide care for that individual. And yet really at the end of the day, they're hoping that that person is removed from their unit as quickly as possible so they don't have to deal with it. It's really harmful. I see through things like the Indigenous Wellness Program, the Indigenous Cultural Helpers, teams like the Arch team to do, again, some of those educational opportunities. And again, to look at not creating sort of an adversarial relationship, but really to call people in and try and meet that individual where they're at it and just try to very gently come to a better understanding and then maybe help to show them that there may be a better way. You know, Arch gets called in a lot of times to deal with these difficult patients and, oh, they're non-compliant and they're just impossible to manage. And it's all of these really negative connotations. And a lot of times what people don't realize is that when we go in and meet with patients, we're there to hear them. We're not there to impose our views or pass judgment. And that's where those different types of relationships are formed. The whole focus of what I do is creating that therapeutic alliance and to really help to build rapport and establish trust with patients. Nothing else is more important than that. It doesn't matter what counseling modality I think I'm going to pull out or how fantastic a counselor I am, how great a social worker I am. If that patient doesn't actually believe that I am there to support them, we're not going anywhere. And that's the really important thing to remember. And again, I go into any situation with awareness, again, of my unearned privilege, of the power and balance that is there simply because they're a patient and I am a care provider. And I go in and try to the very best of my ability to level the playing field and to help them to feel that their voice is as important as any other voice discussing their care, and that they are there to teach as well as perhaps to learn from others. I really want to support that self-efficacy and sort of really reestablishing them as the experts in their lives and their stories.
Okay, thank you for sharing, Corinne. So I think we'll just do one more question. So this is from Julie. Is there anything being done in jails to help people who use drugs rather than just having to detox on their own?
Yeah, I can answer some of those questions. So there is a program from corrections where, I mean, people are started on OAT in corrections. That's been a huge push from Alberta Health Services. Alberta Health Services does have a say in how the corrections health management is being conducted. It's just for Suboxone right now. They've got a set panel, a maximum amount of people that can have on the panel, which is one of the problems that they have to work through right now. But people are usually started in OAT, specifically Suboxone, prior to discharge from corrections facilities. It's tricky in terms of how to get them engaged with treatment in the community thereafter. And that's the tricky part. So one thing that we piloted back in Calgary was the Peer Navigator program from corrections. So we ran that from 2017 to 2019. We lost our funding for that project, but it's pivoted now to what we just talked about earlier is recovery coaches, associated programs. So we actually have our corrections transition team in Calgary working with those same peers to help them transition into the community. And we're working with organizations like eFry and John Howard, who are really there to support these clients. But yeah, it is a huge issue. There is corrections transition teams, but they're usually for high acuity patients who have severe mental health and substance use concerns. But the key here is to sort of scale that back and provide those supports for anyone, because you know that the risk of overdose for people who are exiting corrections is much higher than any other population that exists out there. You know what? You guys just gave me other ideas to where I need to promote NORS. So I appreciate that.
Okay, so thank you so much again to all our speakers and for everyone for participating. I know I learned a lot today, so I hope that all of you have learned something. So the last bit, I'm going to do a draw for prizes. So just a reminder, the first prize is a Starbucks gift card, and then we have some Sony wireless headphones up for draw. So I'll share my screen so that you know that I'm doing this random. And then if you win, just maybe leave a comment in the chat to claim your prize so that we know that you're here. Okay. So the first draw will be for the Starbucks gift card, and I'll go ahead. Okay, so Shay Vander, I'm sorry, I don't know how to pronounce your last name, but if you could please.
Can you draw again? I actually really don't need those compared to the students on the call.
Okay, sure.
Sorry.
I could do another draw.
So weird.
I'm sorry, this wheel is the coolest thing I have seen in ages. I did not know such a thing existed. I am digging this wheel.
Yeah, you know, I didn't really know it existed either until this morning. Okay, so Denise, you have won the headphones, I believe I said was first. So just leave a comment in the chat if you are here. And then I'll do the next spin for the Starbucks gift card. Okay, Ash Davidson. I'm gonna stop sharing my screen so that I can see the chat. See if anyone has claimed their prizes. Okay, perfect. So I'll email you guys to claim your prizes, and then yeah, thank you everyone again for coming. I think this event went really well, and I'm glad that we had so much participation. Thank you again to our wonderful speakers. Your presentations were super valuable, and yeah, I'm really glad that you were able to take the time today to join us. So if no one else has any more comments, then I think everyone's free to go. Thanks again for joining.
Hey, I just have like a really quick question. I just tried to go on to the website and it says it was invalid and I just copied and pasted it.
Oh, the website link?
Yeah, like your guys, like I follow you guys on Instagram. That's how I heard about this. But I wanted to go to your website.
I think our website should be, here, let me just look.
Is there a the in front of it or just?
Yes, there is a the.
Okay.
Yeah, so I might have just put the wrong one in the chat.
Okay, cool. Found it. Yep, there it is. Okay, awesome. Thank you. Thanks so much for this, guys.
Thanks for organizing this, Maya. It was great.
No worries. Thanks for coming, Julia.
I had a good time. See you at the next meeting.
Yeah, see you in a few weeks. Bye.
Bye.